introduction. We had the first part of ECG, and Daniel took you through the basics, took you through the electrophysiology, why you need an ECG, what an ECG is all about. And so I was not there, but I also believe that you guys did, you guys did a few ECGs together, and it's not going to be the first time that we are encountering an ECG. So we are not starting from the scratch, so to speak. Next slide. So this is a recapitulation from the last time. Why do we need an ECG, or as other people call it, why do we need an EKG? The first point that we discussed last time is because it's relatively cheap. I mean, if you compare it to other diagnostics that you need to confirm or to rule out different diagnostics, it's relatively cheap, it's faster, and it's life-saving. What do we mean by life-saving? Once you have your ECG and you have your symptoms, you always have this opportunity to confirm or rule out the red flags. If you confirm the red flags, you can proceed swiftly to do intervention. If you don't confirm or if you rule out a red flag, then it also buys you this time to work on your working hypothesis, or rather working diagnosis. It gives you time to think more, because you basically ruled the things that you feared most. So that's why we do ECG in most clinics. Unfortunately, in Kenya, where most of you people are listening from, ECG is not like a part of diagnostics that is being done by each and every patient. Here in Germany, for example, before you admit anybody, regardless of their symptoms, you have to, first of all, run an ECG when you are working in the emergency room. So next slide. So once you have done your routine ECG, what do you look at, or what do you look at in an ECG? You must have discussed it last time. The first thing you do is to check if you have a sinus rhythm. Can anybody tell us, anybody was there last time, how do you identify a sinus rhythm in ECG? Anybody who listened keenly last week? Oh, you guys slept. I will just summarize how to find out that your ECG has got a sinus rhythm. First of all, you have to look if your ECG has got a P wave, and you have to look that each and every P wave is being followed by a QRS complex. So we have an ECG. Right now you can draw just a minute. Sorry, I had to shut down the door. So you can, if you have a working piece of paper, you can draw your ECG, like the P wave, then you can name it P, QRS, and do the next cycle. So basically, for you to have a sinus rhythm, you have to have a P wave, and you have to have a QRS complex, and each and every P wave has to be followed by a QRS complex. That's the first criteria of finding out if you have a sinus rhythm. The next thing that you have to look at when somebody presents you with an ECG, you have to look at the axis, yeah? What kind of axis do we have? Do we have a normal type, or do we have a pathological type? The most common ones are common, and the most pathological ones are also easier to see. This is something that needs practice. Sorry once again. Gerald? No, they should not do the cleaning today. I'm busy today. Yeah, I'm good. I'm okay. I'll be downstairs in a few. Okay, thank you. Bye-bye. Before, I'm very sorry. I'm very sorry. So the next thing you check in an ECG is the axis, if you have a normal axis, or if you have a pathological axis. The next thing that you want to look at in an ECG is the heart rate. Do you have a heartbeat that is faster than the normal heartbeat, or do you have an heartbeat that is relatively slower? So we call it bradyarrhythmia or tachyarrhythmia. If you listened keenly last time, I believe we discussed, so I believed we had the intervals to be 100 beats per minute. That's the above 100 beats per minute. We call it tachycardia, and below 50 heartbeats per minute, we call it bradycardia. But that also depends on the patient, because to some people, 49 beats per minute could be a normal heartbeat, and that is for people who have done a lot of sports, people who have trained. They basically have a lower heartbeat rate. The most important thing, and what we are going to really concentrate on when we're doing this presentation, are the time intervals. You have the P waves and you have the QRS complex. The time interval is so very important, because today we are going to talk about the AV blocks, and we are going to also talk about the right and the left bundle blocks. So for these ones, it's always important to have your time intervals with you. Next slide. Right. What's also important, and I also believe that we discussed it last time, was basically the conduction of impulses, or rather the conduction of action potential, starting from the sinoatrial node till the Purkinje fibers. So just as it's included here, you have the SA, which is the physiological pace setter. Then from the SA, the impulses travels to the atrium, and it's picked with the heavy nodes. And from the heavy nodes, it goes to the east bundle, which then goes to the left and the right bundle branches, and lastly, the Purkinje fibers. So it's very important to note this one down, because we are going to need it as we proceed. I believe you also discussed last time that each and every structure that is listed here, they generate impulses at various how do we call it? Like if we talk about the SA node, for example, it generates impulses at a frequency of around 70 beats per minute, and the AV node also generates impulses at around maybe 60 or 50 beats per minute. So basically, if the SA node fails as the primary pace setter, the AV automatically comes and replaces the SA node as the secondary pacemaker. And if that fails, the cycle continues. The problem is, if we leave the AV node and go to the His bundle, the frequency of the generated impulse is basically not enough for the heart to do to work efficiently. So it's very important to note that. We move to the next slide. Right. It's also important to know the scaling. I believe you also discussed that last time, that if you have a standardized ECG paper, basically one big box that contains 5 small squares on the horizontal axis, as some people call it the x-axis, equates 200 milliseconds. So if one big box which contains 5 small squares equates 200 milliseconds, mathematically it means a very tiny box, one small box, has to be 0.4 seconds or 40 milliseconds. Next slide. That's too small, but it's basically what's demonstrated here. We have one big square that contains 5 small squares, and each small square is 40 milliseconds. Next. Right, like I said before, today we are going to talk about conduction disorders, and I'm going to major on the AV block, and we will also talk about the bundle blocks, the left bundle branch block and the right bundle branch block. Next. Is there a way that we can zoom the presentation? Right, thank you. Okay, so basically, we see a physiological ECG or a physiological EKG that contains a P wave, contains intervals. And like I said before this, each and every interval is going to be important when we are discussing about the conductive disorders. So the first disorders is going to be the AV block, which is also known as atrioventricular block. Next slide. So it's okay, just leave it like that. So when we talk about the AV block or the atrioventricular block, we have 3 types, which are mild and some are dangerous. We have the 1st degree AV block, we have the 2nd degree, and we have the 3rd degree. Next slide. So up to this point, is anybody having a question or a discussion? Looks like we're good. So let's talk about the 1st grade of AV block. We have various risk factors. The 1st one includes medication like beta blocker, for example, propranolol, metoprolol. Then we also have increased vagal tone, which leads to something that is called negative dromotropy. So when we talk about increased vagal tone, I believe we've all heard about the 10th cranial nerve, that is vagal nerve, which is mostly parasympathetic. And if you remember the physiology of the heart and just general physiology, the parasympathetic, it's mainly active when we are resting and digesting. So if you have an increased vagal tone, it also affects the rate at which the electrical impulses are being transmitted from the atrium to the ventricle. This transmission is called dromotropy. So if we talk about negative dromotropy, it means the speed of the conduction from the AV to the ventricle is basically reduced. That's why we call it negative dromotropy. The opposite is a positive dromotropy, which means the speed of conduction between the AV to the ventricle is basically increased. Right. Another risk factor is degeneration of the conducting system. That's maybe due to old age or due to previous history of infarction that can lead to degeneration. So next slide. As said, as we were starting, that in each and every ECG, we have to make sure that we have a sinus rhythm. And when we talk about disorders, people think that each and every disorder has to be some sort of arrhythmia without sinus rhythm. That's not always the case. As you can see here, when we talk about the AV block, the first grade, it basically means that the time between the contraction of the atrium with the contraction of the ventricle has been prolonged. So if you look at an ECG, you will find that we have a P wave and we have a QRS complex. And in each and every P wave, there is a QRS complex that that precedes it. So it requires somebody to be very, very careful, because if you don't know the physiological timings, you can easily misdiagnose AV block of the first grade. The physiological time, or rather the PR interval, that is the time between the onset of depolarization of the, how do you call it, of the atrium, to the onset of the depolarization of the ventricle, is around 200 milliseconds or 0.2 seconds. So if you have an ECG, the first thing if you have an ECG whereby you suspect an AV block of the first grade, you just have to look at the interval between the onset of the P and the onset of the QRS complex, what we call the PR interval. If it's more than 200 milliseconds, or if it's more than 0.2 seconds, we have a delay, or rather we have an AV block 1. Next step. Zoom it. Right. As you can see, depicted on the screen is a lead 2. That's just a muster. This is lead 2, and we can see there is a P wave. Then can you just point the start of the P wave and point at the start of the QRS complex, right? If we go by our formula, we said before that 1 small square equates to 40 milliseconds. If you look at the time between the onset of the P wave to the onset of the ventricle complex, we have more than, let me see, we basically have around 7 small squares, if I counted correctly. So 7 to 8, around 7 to 8 small squares. So 7, or rather 8 times 40, that's around 320. So this surpasses the threshold, or rather the physiological time that is actually needed. So on the first block of AV block, we just have an increased interval of the PR. More than that, you won't find it. If you don't pay attention, you might miss it because the ECG looks pretty much normal. So what do you do if you find an ECG like this? Normally, if you're working in an emergency room, or if you're working in the Department of Cardiology or just internal medicine, you don't basically give a therapy to the results without clinical symptoms. So in most cases, you find that people with first degree AV block, they don't realize anything. And in most cases, you don't intervene because there are no symptoms. You just leave it like that. If there is any medication that causes this kind of block, like we earlier discussed, if they have like a beta blocker, if they have medication that increases the parasympathetic tonus, or rather the parasympathetic tone, you might want to reduce the doses or just leave out the medication. Next. Right. Here is where it gets interesting. When we talk about the second grade, rather the second degree AV block, we have two types. And I want you to pay attention here. We have two types of AV block of the second grade. The first one is called Morbitz 1, or as other people call it, Wenkenbach. The second one is called Morbitz 2. So the risk factors basically are almost the same to the causes of the AV block of the first grade. But in this case, you have to be to pay attention, because we talked about ECG, checking if we have a sinus rhythm, and checking if each and every P wave has got a QRS complex. We are going to find interesting findings here when you talk of the second degree of AV block. Next. Zoom it a little bit. Right. Now, let's take a look at the second lead 2. Can you show the first P wave and show the first QRS complex? Thank you. Show the second P wave and show the second QRS complex. Now show the third P wave and show the third QRS complex. The question to the audience: did you realize anything? Feel free to answer. Did anybody realize anything?
Yes.
Yeah. Or did you realize?
There is increase in the time of the PR interval.
Right. Would you call it a sinus rhythm?
Yes.
Because?
For every P wave, there is a QRS complex. No, complex after.
Yeah. Do we have anybody with a different suggestion? If you would call this a sinus rhythm, or we would call it something else? Anybody else? Okay, let me just continue. For me, I would not call it a sinus rhythm, because if we stay on the second lead, as you already said, we have like the P wave, then we have the QRS complex, and as it continues, you realize that it comes a point where we don't have a QRS complex. So based on that alone, it disqualifies from being a sinus rhythm. So the AV block second grade type 1, or the Wenkenbach, is very simple to spot on an ECG. You look at the P, and you also look at the QRS complex, and look at the intervals between the P and the QRS complex. You will realize that the first one is maybe 220 milliseconds, the second one is 250 milliseconds, and the third one is maybe 300 milliseconds. And then abruptly, it stops, and the cycle resumes again. Based on that, it's not a sinus rhythm, but it's also not something that is clinically dangerous. Most people that have it may present with dizziness, or sometimes they have blackouts. If they have symptoms, then it's basically a need of intervention. You can intervene by finding the root cause. Let's say if we have like medication that causes it, you can adjust the medication. If you do all your diagnostics and you don't find any cause or anything that relates to the clinics, these patients might be considered for pace setters. Next. Oh, can you just go back again? Right. Right. Zoom it a little bit. Oh, that's too much. Okay. Now we'll talk about the type 2 of the second degree AV block, also known as the morbid type 2. Let's take a look at lead 2 again. I always refer to lead 2, and most clinicians always refer to the second lead, because if you look at the positioning of the electrodes, lead 2 basically looks at the heart from the apex to the top. So if you want to if you have an ECG that is not clear, maybe the patient moved and there are a lot of artifacts, it's always important to look at lead 2. Mostly it gives you a better view than other leads. So if you look at the second lead, do you notice anything? Seems like nobody notices. So let's go through it once again. We show the first P wave, and we show the QRS complex. We show the second one, second P wave, and the second QRS complex. Then we show the third P wave and the third QRS complex. Until now, it looks perfectly okay. But then we proceed. Basically, we don't see anything. So we don't see anything. So common features of the second type of AV block, you will always have the P wave, you will have the QRS complex. But if you move along, at some point, the heart just doesn't beat, it just stops. And you can classify it according to the pattern that is, according to the patterns. If we stick to the second lead, I can count how many QRS complexes. Let me see. Let's start with the P waves. I count 1. I count the second one. And I also count the third one. And after that, we have a P wave that doesn't have a QRS complex. I know it's not cut well, but that's the case. So if you were to describe it, you would describe it as AV block second grade. Then you would go ahead and say 3 to 1, which means you have 3 P waves that are being followed by QRS complexes. Then suddenly you don't have a rhythmic heartbeat. So that basically makes the second degree AV block. It also presents with the patients might present with dizziness, blackouts, and basically if we have these symptoms, it's a red flag and you have to intervene by either finding the root cause. If you don't find the root cause, you can electively implant a pace setter. So next slide. I believe we don't have an example for the third slide. But if we talk about the third degree AV block, here is something that is very dangerous, because normally, or rather physiologically, the conduction begins from the atrium, then goes systematically to the ventricles. But when we talk about the third degree AV block, there is a complete dissociation, which means the atriums contract separately and the ventricle contracts separately. So you might find an ECG whereby you have a frequency of whereby the atrium contracts at a frequency of, let's say, 60 beats per minute, and you go to the ventricle and it contracts at a rate of, let's say, 40. So just independently, which makes it very dangerous. If you see an ECG and unfortunately could not find a licensed most stuff, that's why I didn't include it here. So if you find an ECG where the ventricles and the atriums are totally don't have anything to do with each other, Daniel, do you have one? Let's see. Yeah. We take the second lead, for example. We see QRS complex. We see another QRS complex. Move to the second QRS complex and show the first P. And the second P.
Second P.
Right. So basically, here we see, for example, on the second lead, we have two Ps that don't have a QRS complex. So they conduct independently. The Ps, or rather the atriums, conduct on their own, and the ventricles conduct on their own. So there is no synchronization at all. If you spot an ECG like this is somebody that you don't send back home. It is somebody that you admit, you monitor them. You monitor them. There is something that you call Daniel, what do you call lung static again in English?
A long-time ECG.
Right, you do a long-time ECG. A long-time ECG is basically an ECG that records the events for a maximum of 24 hours. And once you have a record of ECGs within 24 hours, you can analyze it. How many of such incidences do you have? And mostly, if you see this, even without doing this long-time ECG, you would recommend implantation of a pace setter. Good. Can we go back to the presentation 6? I believe it should be done.
The presentation was over, or do you want to go to the next one?
I think it was over.
Yeah.
At this point, is there anything that we need to explain or maybe elucidate more? Does anybody have a question? An addition, subtraction?
Any questions? Yeah, we're doing this for you guys. So if you don't ask the questions, if you don't participate, I don't know how you're going to be able to do this alone. So just turn on your microphones. There is no wrong question. Just ask, and we'll give you examples of more ECGs for you to look at.
You guys are fine.
Yes.
So looks like the audience is fine. We will just summarize at the first part before we move to the second part. So basically, the first part we were dealing with conducting disorders, where we talked about the AV block. We realized that depending on the grade of AV block, it could be harmless or it could be dangerous. So the most important thing, if you have a finding on an ECG, it's always important to correlate it with the clinical symptoms of a patient. If you have somebody who's got an ECG with maybe AV block grade 1, for example, you have to ask for further history or some things you can just diagnose by seeing. Yeah, if these people look trained, if they look muscular, and you spot maybe an AV block first grade, you don't have to worry much because, like we said, one of the causes is increased vagal tone, which is, to those people, physiological. No panic. If you spot a second grade AV block and the patients are young, no past medical history, no past heart conditions, and they don't have any clinical symptoms, you don't really have to intervene. Of course, you have a pathological ECG, but not all pathological ECGs mean you have to intervene. In short, you don't treat the ECG, you treat the patient. You treat the symptoms in correlation with ECG. Right. Daniel, is that my presentation or is this yours? Daniel, are you there?
Yes, I'm here. I'm trying to turn on the presentation for you.
Right.
Number 7.
Do you want to?
Yes, I have a question for those who are listening. Yeah.
Right.
I know people. Before we go to the next level, it's I want us to think about the AV blocks. There are atrioventricular blocks. We just talked about them. So can anyone tell me which AV blocks do we treat and which AV blocks can we just leave for the for follow-up? Anyone? I'm not going to move on until I have an answer. So I need an answer on this.
Let me try.
Yes.
I think for the second degree morbidity 2 and third degree, the ones who can treat, I guess.
Okay, the second degree mode and the third degree mode.
Yeah.
Okay. Now that you have answered, I have a question for you. A 60-year-old patient, female, comes to your emergency sector with a pulse of 35 BPM. Yeah. Just feels a bit dizzy, but is doing fine. All of the other exams are fine. What do you do with the patient? Look at the ECG. You see they have an AV block tube type 2B. How do you proceed with this patient? Just say anything. There's no wrong or right answer. Okay, would you monitor the patient or would you just let the patient remain at the normal ward intermediate care or HDU, what would you do?
Maybe because of the low heart rate.
Mm-hmm.
I think in intermediate.
Okay, you will send the patient in intermediate care.
Yeah.
Okay, what are we afraid of? Can someone help us? What are we afraid of that could happen to this patient?
Cardiac failure.
Hmm? Cardiac failure. What kind of cardiac failure would we expect? What happens? I have a picture here. You have the AV node, you have the sinoatrial nodes, and the block is here. Yeah. So where do we expect the cardiac arrest or failure? In the upper chambers or in the lower chambers?
Right.
Yeah, that's A or B.
The upper.
In the upper chamber.
Yeah.
Okay, so it means if electrical impulse is moving from the sinoatrial node to the AV node, the ventricles, and if you build a wall here, yeah, will you still have electrical impulse in the upper chambers? Yeah,
No.
yeah, the electricity is moving like this. So if you build a wall, you will definitely have electrical impulse on the upper chambers, but the lower chambers will have the issue that the electrical impulse is not moving through the AV nodes to the rest of the muscles. Yeah, you get it. So that's the reason why we have a lower heartbeat. Yeah, as a result, because there is not enough electric activity happening here in the lower chambers of the heart. Yeah, so we have like the heart pumping in a very low mode. So what am I afraid of when we know that the heart is pumping in a very low mode, like 30 BPM or 30 beats per minute? What are we afraid of? Or what happens if the heart only pumps very slow? What happens to the rest of the body?
In short, what's the function of the heart? And what happens if the heart cannot function as it's expected? Don't think of that.
Ischemia.
Deeply. It's just something like it's really superficial.
Yeah.
Na wale wengine hawaongei.
Going to
want to learn. It doesn't make any sense to speak to you and then you go home, and so we're learning here. What's the consequence? Someone
acute heart failure.
A what failure?
Acute heart failure secondary to decreased ventricular function.
Okay, so when the ventricular function decreases, what do we expect on the periphery? Do we expect? Yeah, sorry.
We have a decreased blood supply to the periphery, not commensurating with the demand. So we have ischemia and hypoxia.
So where do we have ischemia when we talk about decreased supply of blood?
The whole body, including the heart.
Okay, so the symptoms of the patients, you're right, the symptoms of the patients will mostly be they keep falling down, they can't stand on their own, they have like blackouts. Yeah, they have blackouts because the brain, the legs, the extremities is not getting enough blood. Okay, so what do you do, sir? What do you do with this patient? Intermediate care or HDU? Or normal ward?
HDU. HDU.
Yeah.
Okay, HDU.
Yes.
Do you escort the patient to the HDU, or do you let one of the nurses bring them?
Ideally, always call the patient because we're trying maybe to cardio convert or something, because we need to increase the ventricular output or ventricular rate.
Okay, how do we increase the ventricular output? And that is the question now. That is, we are now getting much closer to the results that you want. How do you increase? Because if you cardiovert, all you do when you cardiovert is you're bringing the arrhythmia into rhythm. But we want to increase the heartbeat. And we want to make sure the whole of the body is supplied with oxygen and nutrition. So how do we go about this?
Again, think of the physiology. Don't think deeply, think of the physiology. What do you do to increase the output? What do you do to the heart to increase the output?
Increase its pumping action. I think you can give normally give atropine tend to reduce a vagal its vagotomy tend to reduce a vagal action of the vagus nerve, so it increases the cardiac rate.
Okay, but
Yes.
does it make any sense to give atropine? Okay, I'll just ask the question differently. What does atropine do to the heart?
It blocks parasympathetic nervous system.
Okay, so now you're ready. If you have a AV block, 3rd degree, doesn't make any sense to give atropine.
Not really.
Not really, yeah, because yeah, we have a blockage. Okay, so we're talking about a patient with AV block, 2nd degree. Okay, this patient could profit from atropine. Maybe it was a stress day, you're in the ER and you think, oh my God, I'm not sure, is it a 2nd or a 3rd degree? Which other medicine would you propose instead of atropine?
Ionotropic agent, maybe the vitamin or I'm not sure of specific one, maybe epinephrine or the vitamin.
Yeah, what happens to the heart?
Vitamin.
When you give the drug, it tend to have an increase inotropic, that tend to increase the rate of pumping and also the strength.
Okay. Yeah. Okay. It's a possibility, but you have the problem with the vitamin that you need very high doses in order to have an effective heartbeat. Yeah. So you'll have to give it continuously. But what other drug do we have which is most famous? Much more easy to get than the vitamin.
Epinephrine.
Yeah, is adrenaline, practically. Yeah, epinephrine, adrenaline, suprarenin, whatever you call it. So that's a drug which is. So you have the patient. You see the patient has a pulse of 30. The patient is falling unconscious. The first thing you do is you try help the patient to give adrenaline. The pulse rises from 30 to 35. The patient is still unstable. What do you do next? What other simple mechanism do we have in order to maintain the heartbeat? Yeah, someone is now, huh? But we're learning, yeah? Just think. We have the issue that the impulse of the heart, we are missing this part of the heart because the heart is beating in an extreme different way as you expect, yeah? So what other measure could you take immediately? Anyone? Apart from adrenaline or atropine, when it comes to 2nd degree? You want to increase the heartbeat. You want to supply the body with more oxygen. Yeah, so you have two possibilities. Either if you have an AV block, either you increase the heartbeat, but after increasing the heartbeat, it will be also important to maintain the heartbeat. Does anyone know any other method you've seen in Dr. House or Gray's Anatomy anywhere?
I know you can do pacemakers, ventricular pacemakers, but that is more of a surgical care.
Yeah, you have two types of pacemakers. You have the surgical pacemaker, the permanent one, and you have the temporary, the passage pacemaker. Yeah, many people don't know that actually you don't need the surgical pacemaker immediately, but you can have a bridge until when you bring the patient to the ICU, you have a defibrillator, and in this defibrillator, you can always, if you have this in your hospitals, in your ERs, you can put the two pads on the chest of the patient and turn it into a pacemaker by making the heartbeat at 60 rates per minute.
Okay.
Have you ever done or seen this before anywhere?
Not really.
Not really. Okay, so the next time I'll try find maybe a pacemaker here, and I'll maybe show you what I mean. Yeah. So there's the possibility of having a temporary pacemaker on top of the body of the patient in order to increase the heartbeat. The only thing is this kind of pacemaker is a bit, disturbing for the patient because they'll be getting charged every time the heart tries to fall. With the heartbeat, they'll be receiving like electric impulses, and this could be really, not so comfortable for the patient. But it's the best cheap, fast, and non-surgical method of dealing with an AV block 3rd degree and making a patient become stable. So what you do is you put the pacemaker, you give adrenaline or epinephrine using a perfuser, and you make sure that the patient is stable. After the patient is stable, we can now talk about the surgical pacemaker wherever this is going to be done. Okay, people?
Okay, thank you.
Okay, yeah, thank you. You see, now we have learned something more.
Yes.
Yeah, someone asked for us to record the presentation. I will upload it on our YouTube site. So don't worry, we will upload this on our YouTube site and you can look at it later on. Okay, AV blocks 3rd degree, AV block 2nd degree are the most, 3rd degree is the most common cause as to why patients get blackouts. Yeah, if you had your uncle or your aunt, they just came from work and they fell, mostly these are the causes. So if a doctor doesn't come in time, if an ECG is not done in time, you end up losing the patient because of time wastage, disorganization, all of this stuff, and the patient dies, because the heartbeat proceeds from 30, 29, 28, 25, 20, 10, sometimes even in the ICU, I watched patients moving from 42 until 0. We have such cases. So if you have brought the patient to the ICU, you still have a possibility, and you don't have a surgeon in Kisumu, for example, a cardiac surgeon who is able to implant a pacemaker. Do you have any other invasive ways of stabilizing the patient? Does anyone know of another method of pacemaking? There's another method of pacemaking for the ICU for cases where, the life of the patient depends on you because you don't have any cardiac surgeon around, and you want to transport the patient from Kisumu to Nairobi or from a rural area to Nairobi. There's a way where you can use wires, electric wires. Using the pacemaker, which you applied here, you can use the wires to go through the vein, the femoral vein of the patient up to the heart, and the electrodes will then be placed somewhere near the upper right chamber and will be giving electric impulses to the heart and enabling the heart to continue pumping. Yeah, but there is something we have to really practice. It's not something. But now that I know that it's not common, I will maybe try to get my own defibrillator and show it what I mean so that you understand it. Yeah. Okay. Okay. So let's move to the next presentation to save time. And any questions can be asked later. Yeah. Let's move to the next question. And the next session, we will be repeating all of the heart disorders we have learned from now, from atrial fibrillation, platinum, from AV blocks. I'll be showing you different ECGs, and then you will have to tell me what the patient has. It will be very interesting. That will be on the 26th of April. Okay. Jerry, are you ready?
Yeah, let me just add something. We talked about the AV block, and we said the second degree might not be that dangerous, but the moment you see a patient and you diagnose the second degree, you have to monitor this patient closely because, of course, you said it's not like dangerous like the third one, but there are cases where the second degree blockage can, with time, can develop into a third degree. So once you have one ECG that is pathological, it's always important to monitor the patients. You always tell them to come back for control checkups just to see if it progresses or if it disappears on its own, because that's also possible for the blocks just to disappear like that. Okay, we can move to the So this is the second presentation, right? And Daniel, I'm going to need your your help here. As a neurologist, you don't see this much often. So in most cases, I might be the person presenting, but I might as well be hanging. So we will need your experience from cardiology and from internal medicine. Yeah, so LBB and RBB. Who can tell us what this acronym stands for? Faster, guys, let's save time.
LBB stands for left bundle branch block, and then the right bundle branch, or left bundle branch and right bundle branch.
Right, and if we add another B, then it's a left bundle branch block and a right bundle branch block. So once again, we go to the next slide. I will stress it again. It's very, very important to familiarize with the conduction path within the atrium and also within the ventricle, because for you, or rather for us to understand the pathophysiology, we have to be able to understand the conduction path, whether you've been woken up at midnight, whether you've been woken up at whichever time. For you to understand LBB or RBBB, you have to be familiar with the conduction path. So let's just repeat it again. We talked about the primary pace setter, that is the SA node. From SA nodes, the atrium contracts and it goes to the AV node. Then from the AV node, there is a transmission from the atrium to the ventricle. Let's look at the septum. Let's look at the septum. right up after the AV node, we have like a bundle of his, and this bundle of his moves within the septum, and it separates, or rather it branches itself onto the right branch and onto the left branch. If you would have had like a more detailed image, we would have seen that the left ventricle branches again into anterior, into posterior, and into a branch that majorly supplies the septum. So if we talk of the left branch, it can be classified into anterior, posterior, and the septal branch. So next. Right, and we go to the left bundle. I said it before, it's subdivided into anterior, into posterior fascicle. And physiologically, the depolarization, or rather the conduction, or rather the action potential of the left ventricle slightly precedes the depolarization of the right ventricle. So in case we have a left branch block, rather LBB, these things are very tedious for the mouth. But if you have a LBB, if we have a block on the left branch, then it basically means the depolarization on the left side is delayed. When you have a delayed depolarization, I'll take you back to the morphology of QRS complex. If the depolarization is delayed, it changes the morphology of the QRS complex as we know it. I told you before that we need to equip ourselves, or rather to acquaint ourselves with the timing. And physiologically, it takes 120, rather less than 120 milliseconds for a complete depolarization of a ventricle, be it the left ventricle, be it the right ventricle. It takes less than 120 milliseconds. So if we have a block at the left branch, the depolarization is delayed on the left ventricle, and vice versa. If we have a block at the right branch, and the depolarization of the right branch is delayed. Next. I want you to, can you zoom it again? Right. For some, for us to understand the bundle branch blocks, because we will be dealing with the ECGs, we have to familiarize ourselves with the precordial leads. That is the V1 until the V6. If you look at it keenly, you will realize the V1 and the V2 are basically on the right side, and V5 and the V6 are basically on the left side. This is going to be very, very important when you are having an ECG that is pathological, or rather that is a blockage of the right or the left side, and you are primarily not sure, or rather you see a QRS complex that is pathological, but you don't know if it's on the right side or on the left side. Just by taking a keen look at these precordial leads without cramming or without learning it over and over again, you can determine, just by the localization of the pathological QRS complex, you can determine where the block is. We proceed. Next slide. So we start with the right branch bundle block, or whichever you want to call it. So what are the features of this kind of block? As I said, the QRS morphology is very, very important. Physiologically, it's below 120 milliseconds. So if we have a wider QRS complex, it means we have a delay in the depolarization of the ventricle. If we talk of the right side, if the delay is on the right side, then we have a pathological morphology. On the V1, remember I said the precordial electrodes anatomically are arranged in such a way that if we have the V1, it gives you much of an impression of the right side of the heart more than the V6 that gives you an impression of the left side of the heart. So if we have a blockage on the right side, it will manifest itself in form of an M shape in the V1. Then you will also have a prominent S wave in lead 1, and in AVL, you will also have a T inversion in the right precordial leads. Right precordial leads, as we said before, is the V1 and the V2. When we talk about a T wave invasion, you have to correlate it to the QRS complex. If you have a QRS complex that faces up, where the deflection is positive, and the T wave that comes after it has got a negative deflection, then we have an inversion, then it's pathological. So you just have to be very careful when you see a negative T wave. You have to go back and look at the QRS complex to find out if it's facing the same direction or if it's facing the other direction. Otherwise, we don't have an inversion if they face the same direction. What happens if we have a QRS complex that is less than 120 milliseconds, but all other these criteria are fulfilled? Would we say we don't have a block, or what would we say? I know you see the answers, but what would you conclude if you have a QRS complex that is slightly below 120 milliseconds, and you have M shape, and you have a prominent S wave, and you have a T wave inversion? That would basically also be a right bundle bunch block, but an incomplete one. Let's go to the next slide. The pathophysiology. Can you centrate it a little bit? Yeah, I got it. So, like we said before, the conduction path is very, very important. We have the impulse from the atrium that goes to the bundle of His and goes to the LBB, which means, also we are talking about the block on the right branch. So if the right branch is blocked, the physiological path is basically blocked. So it means the right ventricle doesn't get the impulse of depolarization from the right branch. Instead, it gets it from the left branch, which means the left ventricle contracts, and the right ventricle contracts a little bit later. That is why we have a prolonged, or rather a wide QRS complex. I repeat, you have a block on the right side. The impulse will have to go via the left side, then come to the right side. What causes such kind of blockages? You have structural causes, fibrosis that can come with old age, fibrosis that can come as a result of heart attack that is in the past. It can come as a result of pulmonary embolism or other underlying heart conditions. The right bundle bunch block is mostly asymptomatic, but it also doesn't mean that the patients will have a good quality of life. Once you have these, the patients have to be like really monitored to find the root cause and to find the treatment. Let's see what we have on the next slide. We skip this one again. And we skip that one again. We'll come back to it. We skip it. Okay, skip it again. I don't know if I got an ECG on this. Right. So can anybody tell us what kind of ECG we have here? Just starting with lead 1, 2, 3. You tell us, do we have a sinus rhythm? Do we have a normal heartbeat just by looking at it? And do we have time intervals that are within the range? Can somebody just look at this ECG? No, actually, this is a false ECG. Dan, can you please go to the next one? I think this is a false ECG. Right. Can somebody look at this ECG and tell us, or rather tell us what strikes if you look at the ECG? Just starting with lead 1, 2, 3, then going to V1 until V6. Does anybody spot anything that is conspicuous? Anybody? Even if you don't know how to define it, just point out and say, this one doesn't look normal. This part does not look normal. Okay, I'll give you a hint. Can somebody look at the V1 and tell me the differences between the V1 here and the V6 on the same ECG? Guys, it's for you, it's not for me.
There is a T-wave inversion in V1.
Okay.
Yes.
Does anybody also see something else? If you compare the V5 and the V1, for example, do you believe that the timing, or rather the time, the time of the QRS complex of the V5 and that of the V1, can you look at them and tell me something about them? Just try.
In V1, I think
Yeah.
it is prolonged. QRS interval is prolonged compared to V5.
To V5, yeah.
And what did we say about the placement of the precordial electrodes?
V1 tend to provide pathologies or indicate pathologies located on the right side of the heart compared to V5.
Okay.
So probably
good.
it's a right heart issue.
Okay, good. That's good. Now let's go to lead 1, 2, and lead 3. Just by looking at these first 3 leads, can you guess where the axis of the heart points at? The first lead is positive, the second is positive, and the third one is Negative.
Negative.
What kind of axis deviation do we have here? Did you guys talk about axis deviation for the to start with on the first day?
Not yet. Not yet.
Ah. Okay, then that's Does anybody know how to determine the axis deviation?
It's kind of hard. I never got it even in school.
Yeah. Okay. Without going deep into it, the first grade is positive, the second is positive, the third one is negative. If you've seen a lot of ECGs, you will know that this is a left axis deviation. And if you look at the V1, you will realize there is a pathology on the ventricle complex. And we said the precordial leads give us an idea where we have the block. So if we have the block on the right side, it will manifest itself probably on the V1 or on the V2. If you look at this case here, the V1 and even the V2, if you look at it, it's more of a little bit M-shaped. I don't know if anybody sees that.
Yes.
Right. So if you compare it to other QRS complexes, even though we don't have the scaling and the timing here, if you count at it keenly, if this ECG could have been printed out clearly, you would have found out that the QRS complex is on the limit, almost, if not more than 120, then it's on the border. But what I wanted to draw our attention at is the axis deviation. Yeah. Sometimes if you have, I know, if you have a blockage on the, let me think about it. I'm also getting confused. Normally, if you have a blockage on the left side, Dan, you have to correct me on this. You are the cardiologist here. If you have a blockage on the left side, then the axis, the axis shifts to which side? If you have the blockage on the, just a minute.
Yeah.
I have to think. I have to think.
It's difficult for you to see it without a Cabrera circle.
Yeah.
Yeah. I don't have a circle prepared, but we can talk about this in the next session.
Okay. So, without wasting much time, this ECG alone, just by looking at the V1 or the V2, we can conclude that it's right bundle bunch block, because we said for you to determine the pathology on the, whether it's a right or whether it's a left bundle bunch block, you have to go back and look at the precordial electrodes. V1, V2 tells you more about the right side. V5, V6 tells you more about the left side. And that if you look at how the electrodes are being placed, that makes sense. The kind of pathology that you look at in the QRS complex, first of all, is the time within physiological range. Is it less than or is it more than 120? If that's the case, what is the morphology of the T wave? Of the T wave? Is it in? Does it look, or rather, does it correspond to the QRS complex, or is there an inversion? In this case, we see an inversion of the T wave on the V1. You see a negative inversion, and the QRS complex is positive. So our conclusion here would be a left bundle bunch block. Now we go back to the folio, to the slides that we skipped. Just a minute. We go back again. And we go back again until we get to the left bundle bunch block. Go back again. And back again and back again. So left bundle bunch block. This is going to be very important. And Daniel, after I'm done presenting the pathophysiology, I would want you to expound more than this because a left bundle bunch block equates sometimes to a heart attack, and that's why somebody has to take it very, very seriously. More so if you have two ECGs. On the last ECG, the patient had a normal ECG, and spontaneously you see a LBBP, and they have like unspecific clinical symptoms. Some of them just have like stomach ache, some of them just have backache, but then you see a ECG that is suggestive. Anyway, when do we have a left bundle bunch block? There are various types. There could be an anterior, there could be a posterior, and there could be a septal branch block. But this presentation is basically just on the how do you say it, general morphology of a left block. So to start with, the same way as in the same way we have a pathology in the QRS complex by blockage of the right side, is the same way we have a deformity in QRS complex when we talk of the left blockage. But what distinguishes it again is where you find this kind of deformities. As said before, V6 is on the left side, V1 is on the right side. So basically, let's go back to the physiology. The current always moves from negative to positive. And when you have a positive, you always have a deflection going upwards. And just a minute, I have to reprocess my thoughts. I said before, this is not my field. If we have a blockage, then there is a delay. Like if you have a blockage on the left side, then the left side gets to contract later, and contraction basically means depolarization. If you have a block on the left side, it depolarizes later, which means the right side contracts first, and the impulses move from the right side to the left side. That is why we have lack of septal Q waves in 1 and 6. Then we also have a dominant S wave in V1, which sounds paradox because we said V1 represents the right side. But then again, if you look at the way these electrodes, or rather the axes have been placed, they mirror each other, so that what happens on this side is actually the opposite of what happens on the other side. So I'll give you an example first. Let's go to the ECG. Another slide. Another slide. Good. Right. Can we show the V6 here, or it's not included? Good. So we start, we have an ECG here. Can somebody tell us if you have a sinus rhythm or if it's another rhythm altogether?
No.
No means it's a sinus rhythm or it's not?
It's not a sinus rhythm.
Why?
The QRS, it's abnormal.
Somebody else?
It is a sinus, although I've been shown only 2 QRS, but all the 2 had a preceding P wave. I'm not sure if that was, I think that was just a delayed or slowed.
Right, and I don't know what your name is, but you're right. When you talk about sinus rhythm, we said one of the criteria is that we need a P wave, and after P wave, we need a QRS complex. If we take the lead 2, for example, you see there is a P wave and there is a QRS complex. Regardless of the morphology, we just need a P wave and a QRS complex. You go to the second one, we have a P wave and a QRS complex, which makes it a sinus rhythm. What can you tell us about the QRS complexes, either on lead 1, lead 2, or if you go back to the precordial electrode? What can you tell us about them? Think about the scaling and think about the timing. Concentrate on V5 and V6. Does anybody notice any difference, or rather anything that strikes your eyes when you look at the V5 and the V6? Guy,
When I look at,
yeah,
I'll start with V6. So
yeah.
when I look at V6, first I think it's prolonged. The QRS is prolonged, and then there is no Q. It's like, although the Q normally descend below the isoelectric line, but there's no descent, and then it looks more of an M shape.
Just a minute.
Yes.
I would advise us to switch off our microphones if we are not contributing. Continue, please.
Okay, so the first thing is that it is prolonged. The time appears to be more than 120 milliseconds, and then we don't have a Q because normally the Q is below the isoelectric line, but in this one we are just from P and then we are ascending up. Then it look more of an M shape, the way we were saying, or notch. And then in V5, the same thing is prolonged, and it's more of the W form. It's normally that W, yeah.
Right. And what can you say about lead 1 and lead 2? What would you say about the first lead?
The QRS is also widened, and then we don't have the Q. I'm not sure, it's not clear, but in the Q, it is somehow not.
It's not there, so right. Yeah. So we have a sinus rhythm. We have probably also a left axis deviation. And what is the main pathology on this ECG here? I mean, it's self-explanatory. What would you say? Is it a right bundle branch block, or is it a left bundle branch block? And from all that you have seen, would you please make your argument and tell us it's either right or it's a left blockage?
I would say it is left bundle branch block because of first the V6 and V5 have a prolonged QRS interval. We have M-shaped QRS in V6.
Yeah.
And then we have axis deviation.
Right.
Yes.
Daniel, are you there, Daniel? The course is not there.
Yes, I'm here, yeah, of course.
Well, like I said before, that I would need your help when it comes to the length Schenkel block, right Schenkel block. Could you please explain to the group why a left bundle branch block is something that should not be ignored, especially if it's appearing for the first time, and the implications and what could be behind it?
Yeah, I need this to show you. Okay, are you guys still there? We are almost finished, so I'll just show you this picture and explain to you the L-triple-B and R-triple-B again, and then I think we have made it. Yeah. So as you can see here, you have the sinus node, the AV node, and the electrical impulse goes to the right bundle branch and to the left bundle branch. So can anyone tell me where the most heart attacks happen? Which muscles of the heart get involved in an acute myocardial infarction? Anyone? Okay. No one? Has anyone in this group ever seen a heart attack? Okay. Okay.
Let me try.
Yeah.
I think in left ventricle.
In the left ventricle, you're right. So we talk about mostly heart attacks because the left ventricle is the thickest muscle and the muscle responsible for the supply into the body. And if this muscle is involved in a heart attack, you mostly see ST elevations and all of this stuff. So when you have a heart attack, which takes place in the left side of the heart, in the most muscular side, you can see the thickness of the left side. In the most muscular side of the heart, what happens is that if the electrical impulse is blocked on this branch, wherever it is, you will end up having a similar picture like this one. Yeah. In the beginning, please watch what I'm going to do right now. This is my yellow line. So as you can see, you have the isoelectric line, and you have the ST wave, which is a bit elevated. Yeah. In this case, you know that in the most myocardial infarctions, which are mostly dangerous, they are mostly involved with ST elevation of V1 to V3. So what happens is you get an image like this, you get a left bundle block because of the scars which get built in the left side of the heart. This results to a left bundle branch block if the patient is lucky enough, and worst case, it ends up to become just an ST elevation which disappears after a rupture of the heart or when the patient is dead. Yeah. So the thing is, every patient who has an LBBB, which is not known from their consultant physician, they have chest pains, they have to be treated as a primary heart attack or myocardial infarction. Yeah, everything else should be left. Yeah, but if you have a patient who has no symptoms, yeah, a patient who has who is practically healthy, and you have a former ECG where you already had a left bundle branch block, then there's nothing to worry about. So the trick is this: you may end up having a patient who already had his LBBB, gets a heart attack, but you won't be able to see it through an ST elevation because the scars are already built on the left side of the heart. And then you may end up missing the diagnosis. Yeah, so left bundle branch blocks are much more important than the RBBBs, but the RBBBs can also occur as a sign of a heart attack, but more often are this type of ECGs which you find. You don't see any pure ST elevation. Okay, in this case, you see an ST elevation here. You see an ST degradation here on this, on the one, on AVR, AVL, V1 to V4. So practically, you can talk about a heart attack. This patient, I don't know what the patient had, but this is not a normal ECG. Yeah. Okay, so someone was asking, okay. So it's already been answered. So this is a left bundle branch block. Yeah, I'll bring more in the next meeting so that we practice about it. These are right bundle branch block. Remember, concentrate on V1, V2, V3, and V6. Yeah, mostly you have a positive S and a negative T in the RBBB, and in the LBBB you only have here a negative R wave and a positive T wave. Yeah, you see the difference. This goes down like this and then up again, and the right bundle branch block goes like this, up, and a negative T wave, like a repolarization problem. So that is what practically happens. The criteria which you see here isn't enough, isn't not always enough to diagnose a left bundle branch block. The most important thing is to differentiate this ECG from this one. If you're able to differentiate these ECGs by concentrating on V1 to V6, yeah, which is now an RBBB, and here concentrate also on V1 to V6, you will see that you have a negative R wave, positive T wave, but when you come to V6, you have the opposite. You should not get confused when you see this in V6. It doesn't mean that we have a right bundle branch block. It means that the repolarization, according to the axis of the heart, the way you put electrodes, is moving. So you can see the R wave always becoming smaller, going up, becoming a positive wave, and ending up to become a positive wave at the end. Yeah, this is typical for a LBBB. Regarding the RBBB, you will have exactly the opposite. You will have positive waves, negative waves, and during the V waves, the more you go down, the more positive the T wave becomes. And at the end, the T wave becomes a positive T wave. If you're lucky, you have a normal QRS tube. Sometimes you have even a QRS tube, which looks like a LBBB. But you can see that the V1 looks like this, the V6 looks like this, and that's all you have to actually cram in your head if you're not sure of what is happening. Yeah, V1 and V6. Yeah, there's a bridge which I will teach you the next time on how to cram on RBBB and LBBB. Yeah, you can see here RBBB looks like an M, LBBB mostly like a W. Yeah, something like that. Okay, any questions regarding this kind of blocks? Otherwise, we will close the session.
Let me just respond. Somebody asked a question on the chat. That's Ignatius. He asked how we manage, or rather the management options for RBB or left BBB. So if we start with LBB, for example, I didn't discuss that, but it has also got various etiologies, like it can be as a result of acute heart attack, which has to be treated like a STEMI. And if it's not as a result of a heart attack, if it's not as a result of a STEMI, then it could be as a result of high blood pressure, for example, or it could be as a result of a past heart attack. So basically, if we have underlying cause as high blood pressure, then you have to deal with high blood pressure. If you have a previous heart attack in the medical history, then you have to do secondary prophylaxis. You have to make sure that your patient has got something like aspirin, for example. You have to make sure that your patient has got clopidogrel, and sometimes a combination of aspirin and clopidogrel. If we talk about the RBB, the management, also it depends on the root cause. If it's as a result of pulmonary embolism, if it's acute, it also has to be acutely treated with heparins, or nowadays you can treat pulmonary embolism with NOACs, if I'm not wrong, Daniel. You can treat it with NOACs like dabigatran, like Eliquis. I don't know if those are the same name you people use in Kenya. Maybe I'm combining the scientific name and the generic name, but you can use the direct oral anticoagulating agents to manage RBB if the primary cause is a pulmonary embolism. Did I answer your question?
Okay, yeah. Actually, this is easy as treating the causes, yeah, of the LBBB. Otherwise, patients who have a known L or RBBB, they don't have to be treated. Yeah, you can just leave them like that and observe them. And patients who have a newly experienced RBBB or RBBB, then you have to treat the diseases which are mentioned here. Yeah, yeah, that's the thing. Okay, so I believe we have to close the session. Yeah, I think if there were any other questions, I should have already stretched out. I thank you guys for joining us. Remember, the next session is going to be on the 26th of April. I thank you, Jerry, for the great presentation and for the insights. Next time, we'll try working on, yeah, more ECGs, examples, and trying to find out what is normal and what is not normal and how we can treat them. That would be great.
Right.
Yeah.
And maybe in future we can do something neurological, because this internal medicine stuff. Yeah, thank you guys for tuning in, and hope to see you again next time.
Yeah. Okay. Yeah, great. Okay, then I'll just say bye-bye. If there are any further questions, I'll be hanging on here for 5 minutes before I leave. Yeah.